Hi, welcome. Today we're going to be talking about the role of measurement-based care, also known as MBC, in clinical supervision. At the conclusion of this training, participants will be able to define measurement-based care, explain why MBC is important in clinical practice, and explain how MBC can be used in clinical supervision. What is measurement-based care? Measurement-based care is a data-driven method to systematically evaluate treatment progress and inform clinical decision-making in real time, using evidence-based measures like symptom rating scales as a supplement to clinical care. This may sound familiar, as it is sometimes referred to as routine outcome monitoring. We use the term measurement-based care here as we are interested in not just monitoring clinical outcomes, but also using the feedback from our clients in real time to impact approaches to treatment and clinical care. MBC is transdiagnostic, which facilitates use in a wide variety of clinical settings and interactions. It's transdiagnostic, meaning that it is useful for all diagnoses or even clusters of symptoms that may not neatly fall into an ICD-11 or DSM-5 diagnosis. We can track and measure a client's depressive symptoms as well as more specific goals or goal attainment, like making it to class on time. The ability to use structured and psychometrically validated measures, as well as idiographic and client-tailored measures, make MBC extremely flexible. MBC is trans-theoretical, meaning that MBC integrates as a flexible tool that works with different approaches to treatment. As you'll see in the client case we present, treatment approach could go in many different ways. MBC is a tool that can be implemented during structured manualized treatment, as well as less structured organic treatment. In many ways, MBC allows us to quantify and measure clinical and subclinical symptoms and goals, making it an important companion piece to clinical expertise to help promote the best outcomes for our clients. So why should we use MBC? Think of it as feedback in a low feedback field. MBC provides a way to measure client symptoms and goal achievement. We could measure a client's depressive or anxiety symptoms or how often they are meeting a goal they have set in therapy, like getting to class on time. MBC helps us focus clinical decision-making and judgment. As therapists, we are generally an optimistic group, and when relying on clinical judgment alone, we often believe that our clients are getting better. MBC can be used to address this positive clinician bias by providing unbiased quantitative feedback of our client's progress. If the client is getting worse, or if they're just not improving, MBC feedback alerts the clinician so treatment can be altered and adapted sooner than if the clinical decision-making was based on clinician view alone. Through this feedback, MBC can promote learning and collaboration between clinician and client, as well as between supervisor and supervisee. Clinicians can pull up the client records during a session to engage the client in their own treatment and identify patterns together. And as we will discuss in a few slides, supervisor and supervisee can use MBC data to formulate case conceptualizations and plan for the next session with additional information. Finally, tracking client progress, process, and outcomes. MBC can also support decisions regarding when to change treatment plans, which symptoms or goals are the target of treatment, and when we may want to discharge clients who have made sufficient progress and may no longer require regular treatment. Given the evidence in support of using MBC in clinical practice, why doesn't everyone use MBC? Administrative barriers. Providers that do not use MBC in their practice noted implementation challenges like cost, extra paperwork, and time required to score the measures as reason they were not using it. However, as measurement feedback system technology has advanced, feasibility has increased, and many of these barriers have been reduced or removed entirely. There has also been concern regarding measure burden for clients. However, MBC doesn't mean inundating the client with lots of unnecessary measures. Targeted evaluation can help clinicians determine which measures may be helpful to their clinical decision-making. So even in the absence of a measurement feedback system, clinicians can use simple open-source measures or create their own idiographic scales to help monitor their clients' movement towards therapy goals. Concern of MBC being used punitively. Some clinicians are concerned that MBC may be used punitively against them. if their clients aren't improving in the way they would expect or like, that their MBC scores may be used to evaluate their clinical performance. While this is possible, this is not usually the case or how MBC is meant to be used. Its intention is to promote positive client outcomes through proactive and systematic evaluation of client progress. MBC helps us to identify the clients who may need early clinical intervention or a change in treatment sooner than we would have using clinical judgment alone. If anything, by using MBC, you're improving your clinical delivery. And finally, some worry that it replaces clinical expertise with a series of graphs and data points. Having an extra layer of data for clinicians to better understand what is going on with their client between sessions, including how the client feels about the therapeutic relationship, as well as supervisors having more information to help form clinical inferences, makes MBC an important tool in clinical work. How does MBC work with clinical expertise? Repeated assessment acts as an important companion piece to clinical judgment, as well as a companion piece to the therapy session recording in the case of clinical supervisors. What you decide to measure is determined by clinical expertise and may change over time depending on your client's presentation and clinical inferences. MBC allows the clinician to get more information from the client than you can always get during a 50-minute therapy session. This can be especially helpful for supervisors who are overseeing a large caseload of supervisee cases. By looking at the MBC data of those cases, supervisors can get a quick assessment of overall progress and well-being of the clients so they know which cases may require further discussion with their supervisee. To this effect, MBC can be helpful when reformulating case conceptualizations as progress data evolves. Rather than replacing clinical expertise, MBC works alongside it. The MBC that is collected is directly shaped by clinical expertise through measure selection, and information gathered using MBC can inform case conceptualization and reevaluations as progress data evolves. The relationship is cyclical and clinician-driven. What happens when we don't use MBC? We look at our clients through rose-colored glasses. When relying on clinical judgment alone, mental health providers are only able to detect deterioration of symptoms in approximately 21.4% of their clients who have experienced increased symptom severity, and those rates are even lower for clients whose progress has stagnated. If experienced clinicians have trouble identifying deterioration in their clients, you can imagine how challenging it can be for a supervisee to assess how well they're doing as they are just learning how to do therapy. We are also less efficient. MBC can improve accountability and maximize the quality of intervention by clinicians. MBC helps optimize treatment time by helping us identify clients that are deteriorating sooner and to prevent dropout. We are also able to better identify people that are in treatment that may not need it, costing the client more time and money in treatment than necessary. How is MBC used in a therapy session? First, introduce MBC. Discuss MBC with clients, including why you think it's important. Get your clients' buy-in. Check that clients have completed measures before sessions, and if not, understand why they haven't and address the barrier. Integrate MBC feedback into case conceptualization and treatment. Then, utilize the MBC feedback during therapy sessions and pivot treatment as needed based on the data and your clinical expertise. So, how does this translate to clinical supervision? Let's discuss why we should use MBC in supervision. Why use MBC in supervision? Supervisors are responsible for ensuring supervisees learn to use effective therapeutic methods. It's through supervision that supervisees develop general knowledge and therapeutic skills, but supervision also influences attitudes towards care and therapeutic practices. Because of this, supervisors hold much of the responsibility of ensuring that their supervisees become competent clinicians. Supervision itself helps to facilitate constructive feedback in a low feedback field. Just like MBC provides feedback to clinicians on how their clients are doing, clinical supervision works similarly for supervisees, providing detailed and constructive feedback on their therapeutic performance during a session. Using MBC data and supervision together gives even more detailed feedback and support to the supervisee, and positions them well to grow as a clinician. While supervising, you model integration of science and practice. As an evidence-based practice in its own right, MBC can be added to any treatment, and supervisors can demonstrate its role in clinical care regardless of theoretical orientation to treatment. You have a unique opportunity to encourage your supervisees to use MBC, which evidence suggests will serve their client and their training in powerful ways. Where does MBC fit into supervision? Client completes measures. Supervisee receives MBC results. Supervisor and supervisee consult. The supervisee presents their case, and the supervisor reviews the MBC data of the client. Together, the supervisor and supervisee discuss the trends and changes that they have seen over the last set of sessions. They decide on the best course of treatment and make a plan for the next treatment session. Then, supervisee implements the changes in session. Why should supervisors integrate MBC into supervision? Supervisors facilitate change and growth in their supervisees. Supervisors are often the main source, if not the only source, of hands-on clinical training that student clinicians will have while in graduate school. Because of this, you are hugely influential on how they approach their therapy practice and general clinical knowledge. As supervisors, you model best practices, which includes staying current on things in the field, including treatments and approaches. MBC is an evidence-based practice, and being both transdiagnostic and transtheoretical can serve a wide variety of client cases and treatment approaches. By using MBC in supervision, supervisors are provided with extra data which helps paint a more robust clinical picture. These additional data can make you feel more confident going into a supervision because you know how the client has reported feeling. You don't just have to rely on the therapy recording or the notes of your supervisee, you can hear it from the client themselves. This can help evaluate treatment progress more accurately and even help determine how a particular therapeutic relationship is evolving without ever being in the therapy room. An MBC in supervision enhances clinical collaboration and accountability with supervisees through working together to identify patterns and reformulate case conceptualizations together. Supervisors and supervisees collaborate using the client's MBC data by discussing things like proper measure selection and how different interventions may best treat certain symptoms. When supervisors discuss MBC, supervisees learn to track their client's progress and monitor their symptoms more closely, and can come to supervision with specific questions for how they may be able to improve their client outcome or hone a set of therapeutic skills. Identify goals for supervisee learning. Supervisees don't know what they don't know, so MBC can help. MBC can assist supervisors in identifying places for further exploration with a client and make sure that the supervisee knows how to assess for something before confronting it in a session. This can facilitate extra practice before interfacing with a client, leading to more effective client interactions. MBC use in supervision. Now we're going to show you how an integration between MBC and supervision may look. Through a series of brief video clips, we will demonstrate the following ways MBC can be used in supervision. Using progress and process measures to aid in case formulation and planning, addressing supervisee hesitancy regarding MBC, measure selection, using standard and idiographic measures, using graphs to understand symptom patterns, and preparing for client graduation from treatment. In the following video clips, we will discuss a client named Jason. We will show Jason over his course of treatment and how MBC played a role in his case and how it was used during clinical supervision. Jason is a 20-year-old male who reports a depressed mood, whose grades are suffering, and is having issues getting to class on time. Our first video theme is using progress and process measures to aid in case formulation and planning.
Hi, Susan. Hi, Kara. How's it going? Pretty well. How about you?
It's going great. I'm looking forward to. I know that you've been seeing a new client, so I'm looking forward to hearing about how you felt around that initial visit.
Yeah. So the client is Jason. He's a 20-year-old college male.
Mhm.
And he is coming in saying that he's been a little bit depressed, has had issues sleeping, and he's not been making it to class. And so it's been affecting his schoolwork, which has
Mhm.
then also been impacting, his depressive feelings. I did administer the PHQ-9 twice, once on the first phone screen and then once right before our first intake, and he did have elevated scores on that. He has seen a therapist in the past, but he mentioned that he didn't really feel understood or didn't really think that it worked. So that's another thing I want to keep in mind as we move forward.
Yeah, that's really important. And I always recommend this to therapists, that you add a working alliance or a therapeutic alliance questionnaire. We've got the WAISR, which is the Working Alliance Inventory Short Revise. So there's only 4 questions. And I'm sure you know this, but the therapeutic alliance is one of the most critical indicators of outcomes. And I think it's going to be really important for this student, just given his past and that he left therapy. I don't know if he had a conversation with his therapist or not, but monitoring the alliance will, will help you if a rupture, if you're approaching a rupture. And it's something that you'll be able to revisit each week when you review the feedback with him.
Okay, great. So I will add that to his weekly surveys and measures.
Yeah. His
Um,
protocol. That's great.
yeah. Okay, great. Um, and should I talk to him about measuring that before I administer
Ab-
it? Or
Absolutely, 100%. So talk to me around your understanding of an alliance measure and how you think you might introduce it to him.
okay. Um, I think the way I would describe it is that I want to make sure that I'm being as effective and as supportive as possible, but also just making sure that if there's something else I could be doing differently, there's a routine and low stress way for him to communicate his needs to me, to
Mhm.
make sure that we continue to work towards his goals.
Yeah, and when you think about what alliance is, it's really measuring its process, right? It's the
Mhm.
process of how therapy is going on a weekly basis. And so I think that if you just let him know, it's very important to you that he understands what you're working on in treatment and that he feels understood, um, that is a very important part of the whole therapeutic process.
Okay,
And that
great.
if issues do come up, that you're really encouraging him to bring that into treatment so you guys can have a conversation about it.
Okay, great. I'll mention that next time we see each other.
In this next clip, we will address supervisee hesitancy regarding measurement-based care.
Hi, Kara. How are you doing today?
I'm pretty good. Yeah, I don't know. Sessions I think they've been going pretty well so far. So that's good.
Yeah. Who are we going to talk about today? Do you want to talk about Jason?
Yeah, we're gonna talk about Jason again. Um, I don't know. I mean, I kind of wanted to talk to you a little bit more about the surveys I've been sending him before we kind of get
Oh,
into it.
sure.
I guess, I don't know. I guess I get nervous looking at his reports because I'm worried that the scores are gonna tell me that like I'm just not doing a good enough job, or I don't know. We talk about our sessions and group supervision, and I don't know. It doesn't feel like I don't want to be evaluated based on just a few weeks with my client, you know?
Hmm. I see. Yeah, I hear it. I hear that underlying fear, Kara. And what I will tell you is every therapist feels that way when they start using measurement-based care. That the report is somehow going to reflect or reaffirm that imposter syndrome that I think that we all feel sometimes, that, maybe we're not exactly sure what we're doing. But let me alleviate some of that anxiety by telling you that A, you're never going to be judged on your feedback. That anything that is built into performance really is around whether or not you're actually sending measures out to your clients. The whole point, we are in a very low feedback field. And without that feedback, we all have blind spots. So the power behind measurement-based care is that we get additional information that enhances our clinical decision making. It may reaffirm our intuition about what's happening, or it may run counter to our intuition. And that's the power behind it. Sometimes you might feel like the client that you're working with is over reporting on a report, or they're under reporting. That's all clinical information for you to bring back into session, right? Every time you pull up a report, you are drawing a clinical hypothesis, and then that is what you're bringing back into session and you're reviewing that. Let's say though, that you're dealing with a client and you really are struggling with interventions to use. Let's say you've got a client that has a severe eating disorder, and you know what, you're not really sure what to do with somebody with an eating disorder. That's what supervision is for, right? So we can also use, so feedback can also help you as the therapist become more aware of areas that maybe you want to get more training in. And lastly, let me say one more thing, that the report is also very powerful in showing both your client and you that what is happening in therapy is working or not working, right? And that's why that frequent feedback to you as the therapist, you can use to tweak treatment. Does that make sense?
Yeah, that definitely makes sense. I think that makes me feel a little bit better too. Sometimes it's hard when you see a graph or numbers that it feels very just, evaluative of just me. And I guess you're right. It's really more about the work we're doing in therapy.
Exactly.
And if I get feedback that is maybe not as positive, or we're not moving forward in the way that I'd like, that's just really more information for me to figure out what I can change or do differently to improve that.
Exactly. I have clinicians that have been in the field for 25 years and say, I don't need measurement-based care. And what I say to them, do you know the research shows it doesn't matter if you're brand new to the field or if you've been in the field for 25 years, it doesn't necessarily make you better. Again,
Hmm.
going back to a very low feedback field, we have to get feedback so that we also can improve.
Yeah. And I guess in some ways it kind of, I don't know, it makes me feel a little bit more like the client in a way. I know that, Jason has been willing to fill out all of the measures. Obviously, he's been, great with doing that. But I know that he feels a little bit apprehensive sometimes if, he's like, I didn't feel that good this week and I don't want you to be upset or something like that. So I don't know. I guess I could probably talk to him a little bit about how I feel about measurement-based care too, and that we're both kind of in it together, and it's really to move us forward um, and
I,
help him feel his best.
I think that is so spot on. The way I described MBC sometimes is that, when we're in therapy, it's a very intimate exchange of energy. And that when we pull up a feedback report, it can feel like a stranger in the room. And so you are learning as a therapist. You're learning as a therapist, and you're also now learning measurement-based care. And it can be very clunky and very awkward to try to bring that into session in an organic way. That takes time. That's part of the learning curve. And so be very transparent with your client and let them know why you're using it, how it's going to help improve outcomes, improve the therapeutic process, and that you're learning together. And um, and I think that that will also just sort of allow that space for both of you to be able to learn and look at the feedback together without that additional stress that you have to do everything perfectly.
Okay. Yeah, that makes a lot of sense. That makes me feel a lot better too.
Oh, good. I'm so glad. You're not
Okay, cool.
alone. We all feel this way when we start using measurement-based care.
Okay, great. Well, I'm glad I brought it up. I wasn't sure how it would go, so I'm glad I said something.
Me too. Okay, now let's just jump into the report. How does that sound?
Okay, that sounds good.
Okay.
Great.
In this next video, supervisor and supervisee will discuss proper measure selection for Jason.
So this week in session, Jason and I were really trying to figure out what may have been happening when he first started noticing he was more depressed and more tired and having issues with class. And he mentioned that he actually joined a fraternity, um, which made me kind of wonder a little bit more about his substance use and alcohol use specifically.
Hmm.
Um, so I'm thinking I might add the audit to his protocol, just to kind of get an idea of how often he is drinking.
Yeah, and I really I think that I like that line of thinking, Kara. I think what comes up for me, here is a young kid in college. Do you know if he's doing anything outside of just drinking? Is he vaping? Is he smoking marijuana? Is he, you know, taking any pills? Do you know if did you follow that line of questioning with him? That if was there anything outside of the drinking that he might be doing?
We kind of started to talk about it, but then something else came up and I didn't really get to ask all the questions I wanted to, so I'm not really sure about any other sort of substance use.
And did he give any indicator at all that he is concerned about the drinking, or was he just sort of telling you just
He didn't seem concerned. It was, I mean, I think in a lot of ways he's found this new community to be kind of nice, like more friends and parties and social things. But
Mhm.
from what I know about, a lot of, I mean, partying in college is you might be drinking more than you used to. So he didn't seem concerned, but I think there could be a relationship there.
Absolutely, and then that's going to increase his depressive symptoms. I don't know if
Mhm.
you guys had a chance to talk about that yet, or have,
Not a
or even.
ton.
All right. Well, this is okay. So, what I would recommend, there's the audit, but there's also the audit C+2. And so it's two additional questions because the audit is specific to alcohol use. And those two additional questions, one is specific to marijuana and the other is illegal drugs. But you might want to think about when you're introducing the measure to him, let him know about these additional two questions and say, even though the last question talks about illegal drugs, think about it anything outside of, alcohol that you might be using that could impact your depressive symptoms. That could be stuff like, you know, are you smoking, vaping or using tobacco, these different kinds of things. And that'll help us monitor if what you're using is actually increasing your depression. Is that something, you could talk about it in this way to him, and you could say, is that something that you're interested in monitoring through, through the feedback we're using together, something like that.
Okay, that's a good idea. Yeah, I actually wasn't familiar with that measure. So I'll add the audit C+2 instead of the audit, and see if we capture anything that I didn't hear about during our first few sessions.
Great. I think that's a really good idea.
Okay, great.
In this clip, supervisor and supervisee will use standard and idiographic measures in Jason's care plan.
So it was really interesting because you suggested I assign the audit C+2, and
Hmm.
I discussed that with Jason prior to administering it. And it was really interesting because the next time in session, he actually mentioned that he uses a vape pretty often, which he hadn't mentioned before. Um, and so I was wondering if you think that could be related to any of his depressive symptoms.
Yeah, I mean, certainly what we know is that the more substances you introduce into your life, that it has an impact. What that impact is, we can never be for certain. I mean, like I said, we know that alcohol increases depressive symptoms, right? I mean, we know that. I don't know what he's vaping, right? Is he vaping marijuana? Is he vaping nicotine? I don't know what is, do you know what he's vaping? Did he get into?
Yeah, I think it's more of a nicotine vape, because on the audit C+2, he did say that he was maybe using marijuana. I think it said maybe once a month or less. So I think that the vape is more of some sort of nicotine product.
Yeah, so now we've got the nicotine, we've got the alcohol. So even though the audit C2, as I had said to you last time we chatted, that you could say to him, hey, the last item is about illegal drugs, and that could include anything that he might be using out. Because what you're really trying to help him figure out is if all of these substances that he is using, to help him see if there is an actual correlation between the increase in his depressive symptoms. But another option is you could create an idiographic measure that is specific to vaping.
Okay, so like a custom measure just for vaping.
Yeah, it's not going to give you cutoff scores or anything like that. Obviously you don't have any psychometrics around it, so it's not like a clinically valid measure, but it will certainly give you information on a week-to-week basis on helping him to monitor his use and if that is having impact on his depression.
Okay, yeah, that's a good idea. I mean, we have talked a little bit about in session, um, working to help him identify what he's feeling when he's reaching or thinking about, drinking and things like that. So maybe we could have an item trying to see if he can identify how he's feeling when he's reaching for his vape or something like that, to see if he notices any sort of, relationship there between vaping and emotionality or arousal or something like that.
Or drinking, right? Sometimes we
Right.
know that oftentimes people, when they drink, drinking and smoking go hand in hand. And so
Mhm.
that will also, that will also be a nice, that'll just be some additional information too, is what is, like you said, what's triggering it? Is he picking up only when he drinks? Is he picking up before an exam because he's anxious? So I think it really is helping him connect behavior to what is going on emotionally for him.
Okay, great. I will add that to our protocol and, kind of talk through those items with him as well. So
Great.
great. Cool. Thanks.
Awesome.
In the next clip, supervisor and supervisee will use graphs to understand symptom patterns. Yeah, so Jason and I have seen each other a few times since you and I last spoke. And things have been going pretty well, actually. And I wanted to show you some of his graphs from his PHQ-9 and his audit C+2, actually.
Sure.
There does seem to be a pretty clear relationship between his alcohol use and his depressive symptoms. Um, when I first administered and sent him the audit C, you know, things were still pretty high, but then he had a week where he was really just purposely trying to cut back on drinking. And
I see that.
his PHQ-9 dropped to the mild range, actually, from the moderate severe range from a few weeks before.
Yeah, and he
Uh,
dropped in the audit too, and then I can see, so it looks like he started using again, and then there was a spike in the PHQ-9, which, I mean, that was sort of your clinical hypothesis anyways, right? And going back to you and I, what we had talked about early on when you started using measures, what's beautiful about this and what's powerful is that it reaffirms your clinical hypothesis that you had made, that you thought that his use of alcohol had this direct impact on his depression, but now he gets to see that as well.
mhm.
So tell me how he reacted when you were able to show him this.
Yeah, I mean, I had shared with him along the way what I was thinking about the connection with his alcohol use and his depression or depressive symptoms. And he kind of bought it, but he was like, okay, I'll try it. He kind of thought of all these social interactions being
really fun. So I don't think he originally saw the connection between the actual substance use. But when I actually showed him his measures, he was pretty surprised how related they looked. I was like, look at this time and this date, and how you scored on the PHQ-9, and then look at this date. What was happening? Okay, you were trying not to drink. You had something coming up. And then there was some sort of recruitment event again, and you started drinking more, some sort of like fraternity party or something. Um, and he was not feeling good that week. Things got significantly worse. So I do think he was pretty surprised by how related they were.
So what happened as a result? Where did you take the session from there?
So we talked a little bit more about it, and completely not like stopping drinking entirely. That doesn't seem to be something that he's interested in doing. However, he is interested in reducing his drinking, which did show a pretty, a strong effect on his depressive symptoms. So he's going to just be a little bit more aware when deciding how much to drink and when. We talked about maybe implementing some sort of plan where him only drinking, a few nights a week just to try to reduce use first. But I'm hopeful that as he sees that he's feeling better, he'll want to maybe stop completely.
Yeah, because we know, I mean, the one thing that we do know with substance, when people are abusing substances, that cutting back often fails. So,
Hmm.
but that's okay. I mean, I think that what's really important here is that the feedback is helping him to gain insight into his use and how that's impacting his mental health, right?
Hmm.
And so great work, Karis, truly. I look forward to hearing how the next few weeks go with this new commitment to try to cut back and see the impact.
Yeah, thank you. Yeah, he actually, I know we talked about the idiographic measures last week also, as far as his vaping.
Hmm.
Um, and it does seem like he tends to vape when he's drinking. Um, and so he's also just decided to keep an eye on that. And we added a new goal for him to try to identify, if there's some sort of emotion related to his vape usage when he's not drinking and using. So he's
Yeah,
still, I did hear that he was committed and interested in reducing that use also. So that was good to see.
yeah. I mean, this is, I'm so excited that you're getting to really experience the impact too in your practice. Um, Great. Well, I look forward to hearing about how things are going over the next couple weeks.
Awesome. Great. Thanks. Me too.
Yeah.
In the final clip, supervisor and supervisee will discuss preparing to graduate the client from treatment.
Hey, Susan.
Hi, how you doing this week?
I'm good. Yeah, things have been going super, super well. And Jason's doing awesome. Uh, Sessions have been super fun. He's been doing great in school. I mean, his drinking is, he's reduced a lot, and he's actually finally kind of in the green on the PHQ-9. He has like mild symptoms to almost no symptoms. It's been amazing.
Wow, that's incredible. I
Mhm.
that is great news. And how is he feeling about it? So I love to hear the reaction because I told you early on that I love the way our feedback can be a way to celebrate their success because I think that, in the longer you're in practice, you're going to really start to see this that sometimes, the clients that we see have such complex things going on in their life that they often don't recognize when they're making that kind of progress. So I'm just interested, what was his reaction when you brought up the feedback report and he saw just how far he's come since treatment started?
He was really excited and overjoyed. I think there is something about honestly seeing it graphically, like mapped out, to show how far he's come, I think was really impactful. Um, I don't know. I mean, I think that I mean, we love working together. I really look forward to our sessions. I know he does too. And so yeah, he was excited and I think even more motivated to continue maintaining some of the changes that we've, implemented over the last few weeks together. So it's been great.
That's fantastic. Well, show me. I can't wait to see. I can't wait to see the feedback.
Yeah, so you can see his audit C +2.
Wow.
Yeah. Yeah, so he's still drinking, a few drinks occasionally during the week, which, in my opinion is probably to be expected. But you can see his PHQ-9, like he's doing amazing. Yeah, almost like right now he's at no symptoms of depression.
It's amazing. And look at your therapeutic alliance, right? I always love to point that out because I think that goes hand in hand too. Obviously you have created a really beautiful working relationship with him.
Mhm.
And you've been pulling up your feedback, you've been reviewing it in session. All of that really helps to keep you on the same page in terms of what's being worked on.
Mhm.
Really great job.
Yeah, thank you. Yeah, it's actually, at first I always enjoyed our sessions, but now that he's made such amazing progress, I feel like um yeah, it's just been like it's been really fun. So it's been great.
So I have a question for you, just based
Mhm.
on what I'm seeing here. Have you started to think about discharging?
No, not yet. I feel like we finally are in a place where sessions are, I don't know, it's just been really great. And I don't know, I just don't feel like I'm ready to terminate that yet. I feel like we could probably find other things to work on.
Yes. And I'm laughing because I know that feeling. We're always told in our field that, you're not supposed to take things personally, but of course we do. We're human. We get our clients get attached to us, and sometimes we get attached to them too. But one thing that we do know in this field, that sometimes we can hang on to our clients too long. Sometimes we can discharge them prematurely. And what the feedback, so you've seen the power of feedback, of of how that can be useful to inform your weekly treatment sessions, but it's
Mhm.
also useful to help both you and the client to know when you need to start having that conversation about discharge. And it can be
Okay.
scary for your client, it can be, but they can always come back.
I
So
don't
tell
want
me
to
what
I
you
don't want to yet, but I know you're right. Um, okay. I guess I think next time we meet, I'll start talking to him a little bit more about, maybe trying to increase other sorts of support in his life for when we stop meeting at some point. Um, Probably in the next month or so, I guess.
or the next
Um,
couple of sessions, Kara.
okay, okay. Okay.
Yeah, and I think it's fine to see him a couple of more times to make sure that this is maintained, right? Because we know in treatment, things can go up and down. Um, but what I'm seeing here is a really nice indicator that he came in for depression, you did your work, he, you were able to help him draw the connection between the substances that he's using and how that impacts his mental health. And now we're seeing that, he made the changes necessary to help improve his mental health.
Mhm.
So, you can start having that conversation, and maybe you see him a couple of more times. And I think the important piece is, how do you help him, that discharge planning? How do you help him come up with a plan so he can maintain this?
Okay. Okay. We can start working on that, I guess. I know you're right, and I know that's the right thing to do, but I'm definitely going to miss our sessions together. So,
How can MBC be used in supervision? As we have shown, MBC can play an important role in many parts of clinical supervision. It can be important in refining case conceptualization and the treatment plan. It can help you measure symptoms as well as therapeutic alliance, which plays an important role in clinical treatment. Some supervisees may experience some hesitancy regarding using MBC in their own practice. As a supervisor, you can educate them about MBC's benefits and how it promotes positive client outcomes. Supervisors are integral to proper measure selection and knowing what measures may help provide the most robust clinical picture you can get. Asking an additional question or two may impact your treatment goals. Using standard and idiographic measures can also help track your client's progress towards treatment goals, which are goals your trainee can set in session with their client as well as with you during supervision. Using graphs to understand symptom patterns can help demonstrate the relationship between certain behaviors and symptoms, and reviewing them during supervision allows close evaluation of these relationships so you can plan for the next client session. And finally, MBC is a tool that can help us determine when it is time to graduate our clients from treatment. What did we cover? Measurement-based care is a data-driven method to systematically evaluate treatment progress and inform clinical decision-making in real time using evidence-based measures like symptom rating scales. MBC is important to clinical practice because it provides us a way to measure client outcomes and goal achievement. MBC helps us focus clinical decision-making and judgment while promoting learning and collaboration between clinician and client, as well as between supervisor and supervisee. MBC can also support decisions regarding when to change treatment plans by tracking client progress, process, and outcomes. And as we discussed in our video clips, MBC can be used in supervision in a variety of ways. It is also crucial because supervisors are responsible for ensuring supervisees learn to use effective therapeutic methods. While supervising, you model the integration of science and practice, and as an evidence-based practice in its own right, MBC can be added into any treatment, and supervisors can demonstrate its role in clinical care regardless of theoretical orientation to treatment. So why is this all important? We are in a low feedback field, and by modeling MBC use during supervision, supervisors can change that. Supervisors have the power to facilitate change and growth within their supervisees with the feedback we get from the combination of MBC data and their own clinical expertise. The adoption of this transdiagnostic and transtheoretical evidence-based practice has the power to improve client outcomes by improving our ability to pivot treatment sooner and to provide extra support to clinical supervisors through a layer of data which helps inform treatment decisions. How to receive CE credit. Complete all 3 surveys. You have already completed Survey 1. Please take the survey that accompanied the link to this video following this presentation. The final survey will be delivered to you via email in 1 month. Thank you again for your participation.